all the presidents and secretaries of South Zone Kfog societies, like from Trivandrum, Dr. Bindu Madam and Dr. Reggie Mohan, and from Kollam Society, President and Secretary Dr. Annamma and Dr. Ansi, and from Adur Society, Dr. Prasanna Kumari Madam and Dr. Anusmita, and from Kottayam Society, Dr. Anita Gopal and Rani Lakshmi, and from Alapuja Society, Lalitambika and Tangu Thomas also. I welcome all the faculties who are participating in this series, and also the panel members, moderators, and also the members of all these societies and the delegates who are joining this meeting. Before that, I want to apologize to Alapuja Society. Today they are having their monthly meeting also. Sorry for this overlap. Just because our webinar series got postponed, it is incidentally, it is overlapped with your society meeting. Next time onwards, we'll see to it that it won't happen. I welcome you all, and I request Dr. Rani Lakshmi, the Secretary of Kottayam Society, to introduce our chief guest and our guest of honor, Dr. Bhagya Lakshmi Nayak and Dr. G.B. Das. Over to Dr. Rani Lakshmi. Madam, I can't hear you. You have to unmute, madam.
Good evening, all. I'm Secretary of the Kottayam ONG Society. I'm happy to introduce. At first, let me welcome Sujitra Madam, Past President, Dr. Kunjumuddin Sir, and all the chief guests, Sir, Bhagilakshmi Madam, G.B. Das Sir, and our Chairperson of the Adolescent Committee, Maya Madam, and all the panelists and the speakers. My job is to introduce our chief guest today, Dr. Bhagilakshmi. Madam is well known in the field of gynec-oncology. She's a professor in the Department of Gynec-Oncology, Cuttack. She has been the chairperson of the Oncology Committee, FOXI, governing council member of ICOG, and she's the president of AOGI in India. And she's honorary secretary of AGOI. And she has been the assistant editor and peer reviewer for the Indian Journal of Gynec-Oncology. And I think she's the winner of various awards in different fields. And I welcome Madam to this webinar session.
Yeah, thank you so much. Thank you so much, Lakshmi, for those kind words. But I'm afraid that my voice is breaking, but that's all the network that I have because I am in Salem actually. So, and thank you so much, Dr. Subhas and the entire Kerala team for inviting me and giving me this opportunity. And really thankful to all of you there. But then the scientific program which I was looking at has been curated so well. I have no words to appreciate. And I think I really welcome all of you, Dr. Bindu, Dr. Anita, Dr. Prasanna Kumari, Dr. Annamma, Dr. Lalitambika, Dr. Unikrishna. I think you are a huge gamut of all learned persons who have come together. And my best regards also to G.B. Das sir, who is a very senior member in FOXI from Siliguri. Sir, my best regards to you. And I actually appreciate the scientific content of what has been is going to come after this a little inauguration of whatever I have to say to all of you. But then thank you very much. And this is really going to translate to improvement in patient care, because we are the first point reference to all of these small problems that we have. And most of us actually have a difficulty, those who are practicing gynecologists have difficulty in tackling these problems. And I think the whole program will throw a lot of light on all these practicing points, and at the end of the session we'll have all our doubts cleared, and maybe we'll be richer in knowledge about all the problems of adolescents. So thank you again, Dr. Maya and Dr. Shubhas, for giving me this opportunity, and all my best wishes for the webinar. And thank you all Kerala societies. Thank you so much.
Thank you, madam. I request Dr. Subhash to introduce our guest of honor, Dr. G.B. Das. Dr. Subhash Malya, unmute. So we can't hear you, sir. Dr. Subhash Malya.
Hi everyone. Good evening, everyone. Good evening, madam. And I'm really happy to introduce Dr. G.B. Das sir. Dr. Jibidar sir is the director of Ramakrishna Seva Sadan and New Ramakrishna Seva Sadan at Shiliguri. And it's been a wonderful event that we had about 3 months back at Siliguri. Thank you very much, Jibidar sir. He's the current president of the Siliguri Oxford Chinese Society, and is one of the prominent members of the Bengal Association also. Sir has also been very, very active in IMA, and I've met once, sir, and of course Priyanka's father also at IMA meet in national event about 4-5 years back. And I'm very happy to invite Dr. Jibidar sir for this as our guest of honor for the Kerala Federation meeting, sir. Thank you, sir. Jibidar sir, we invite you for your kind words, sir.
Thanks to all the members of Kerala Society. It is an honor on my part to be honored by the Kerala Society. So I'm a practicing gynecologist and with the association with Foxy for last 30 years. And I'm so happy that you have been doing this academic activity. Am I audible?
Yes,
Yes,
Am I
sir.
audible?
Yes, sir. Yes, sir.
So that in fostering knowledge and then the awareness among the doctors and also which can inculcate to only the patients. You have been doing a wonderful job. Kerala Society has been forefront for distributions of the knowledge, and this seminar will be also great help to the practicing doctors. I wish all the best for this academic activity. Bangalore, madam, I also thank you and hope to meet you all again in our next program of July Isan next year. Thank you. Thank you and good evening, all of you. Thank you.
Thank you very much, sir. May I invite Dr. Kujumadi sir to please give a couple of words, sir, please, sir. Can you share a couple of words, sir? Jibidar sir and Kujumadi sir. Kujumadi.
Okay. Thank you.
Yeah. Good evening, Jibidar sir. So we met during the Siliguri East Zone Foxy conference. Sir, it was a really fantastic meeting. Bhagyalakshmi madam, thank you for joining us to inaugurate today's session. I just returned back from Salem from the TNFOG meeting and request the support of Dr. Jibidar sir and Bhagyalakshmi madam for my candidature for Foxy Research Committee chairperson. Please support sir and please help.
Okay. Thank
Yes,
you.
yes.
Sir, madam.
Bhagyalakshmi madam, good evening, madam. Good evening, madam.
Good evening, Shubhas. Good evening. Please carry on. Please carry on.
I request Rani madam to continue, Dr. Rani.
Next, we'll go on to the next session. That's with the academy session proper. That's we have a chair as chairperson, Dr. Mohana madam. Madam has
Dr. Rani, you have to have the address by the President Kerala Federation.
okay.
Okay.
Okay, sir.
Madam,
Sorry.
request.
I invite Dr. Sujitra madam to give the presidential address. Welcome, madam.
Good
Madam
evening.
has been, madam is an excellent figure. She has changed the face of the Kerala Federation of Obstetrics and Gynecology. She's very smart and she has her own way of doing all the things, means coordinating everyone. I'm very happy to work with her. And she has been editor of the Kfog. Now she's the president of the Kfog. She's from Mattanur, Kerala. Welcome, madam.
Thank you, Dr. Rani Lakshmi. I'm indeed very happy that Adolescent Committee, headed by Dr. Maya Malya, she is the chairperson. Recently, she has been elected. And this is the first adolescent webinar which is taking place in this year. Actually, I have been adolescent chairperson many years ago, and adolescent classes have been a passion with me. Before Kfog, I was doing adolescent sessions for Lions right from 2005 onwards. And I had got the International President's Gold Medal for conducting adolescent classes for more than 2 lakhs of girls. So this is something that has been a part of my life. Even today, I go to many places to take classes. And actually, in my home society, that is Kanno, we started the adolescent committee, and I had named it as Talir. Talir means a tender shoot. And Talir, the long form is Teenage Health and Living It Right. THALIR. And to tell you honestly, after we started the Talir, we started involving many of the government officials, the panchayat, the municipality. And the very next year, the government actually started this program. And we used to be called to take classes in many, I'm sure many of you all have been going to these classes. So it was really something very happy for me, because teenage is a very, it's a transitional phase. They are too young to be called an adult and too old to be called a child. That is in between the two situations. So the changeover period is a bit painful, because they find that suddenly the hormones start coming and they are getting all sorts of feelings, and they are getting pimples, they are becoming more, the body shape is changing, and they are having a lot of ups and downs in the day itself. So teenagers need a guiding hand, a gentle guiding hand, so that they won't go astray. And especially today, with all these online programs, I mean, this net programs, and people making friends over the net, and then using drugs also. All these are happening in these adolescent years, because in these years, there is a chance for people to take a risk. The children have that risk-taking mentality. And it is the need of the hour that we gynecologists give a helping hand, give a guiding hand to them. So we know that there are a lot of problems, and today's program is very nicely curated. That is when periods hurt. Dr. Unikrishnan is going to talk about, and menstrual irregularity in teens. We know it is very common. So many, every other child has problems, delayed periods in between spotting, etc. HPV vaccine, a lot of misconceptions about the HPV vaccines, and also building a teen-friendly gynec OPD. This is very important, because teenagers feel very shy to come to the gynec OPD. They think that, what will people think? We are going to a gynecologist. They may think many things about us. So we have to make it friendly, keep it out of the usual OPD hours, have a friendly approach towards them, and see that they don't feel embarrassed. So all these topics are wonderful, and we are so happy to have Dr. Bhagyalakshmi Naik as the chief guest, and Dr. GB Das as the guest of honor, and my immediate past president, Dr. Kunya Mohiddin. So he is the brain behind these webinars. My hats off to him. He's a real genius. And Subhash Malya, what shall I say, the young, active, and vibrant young Secretary General of Kfog. And all these galaxy of stars over here. So I wish you all the best, and with great pleasure, I inaugurate this program. Thank you so much.
Madam, Sujita Madam, because actually I started hearing about you almost a decade back from the Alliance team here in Perindalmana, that there is a doctor in Kannur who used to take a lot of classes for the adolescent. Later on only I met you as president of Kannur Society in person, and during your tenure as adolescent gynecology chairperson, that the program Talir has taken a big role. And Dr. Maya, when you have a leader like Dr. Sujitra ma'am, I think that program has to take it to next level physically.
Thank you, Dr. Hunyamaldi. That's very kind of you.
Thank you, sir.
Wonderful work that you have done. Really happy.
Thank you, madam.
So shall we move on to the next session, madam? Okay,
Yeah,
thank you
please.
for the kind words, madam. And it was really, I think, an encouragement on our part. I think all the participants today, I think they should hear from madam and learn from madam what she was telling. The points were all exactly correct. The teens are embarrassed to come to the OPD, our OPD. People will look at them in another way. That's what they think. And even when the teens are bleeding, the mothers won't bring them to the OPD and they'll end up with a hemoglobin at 4 and 3 and all. So I think we should one aspect we should concentrate on the adolescents too much. We should give them equal importance as menopause, and adolescents should be given equal importance. Madam, I think I will also take your words and we'll start more. We'll also try to get the President's Award like you. Okay. Sir, shall we move on to the next session, Maya?
Yes,
Yeah,
ma'am.
yeah.
Yes, madam.
Please.
Next, we'll move on to the academic session proper. Academic session proper. I like to welcome the chairperson, Dr. Mohana. She's from Kollam. She had her MD from JIPMER, and she's now a consultant gynec, and she's practicing both obstetrics and gynecology. Welcome, madam.
Thank you. Thank you. Good evening, all of you.
Good evening, madam.
Namaste. Namaste, madam. Good evening.
First of all, let me thank the organizers for giving me an opportunity to chair this session on first consultation matters. The first topic is when period hurts, evaluation and management of adolescent dysmenorrhea. The spasmodic dysmenorrhea is known time immemorial. Gone are the days our mothers used to tell us, please bear. If you bear it, you will be able to bear the labor pain better. But now the teens are very, very active. They are always hunting for higher education centers, for jobs, etc. They cannot afford to lose even one day of life with bleeding and pain, etc. And my congestive element is also cropping up because of premature menarche and long periods of menstruation. Thanks for the imaging modalities like ultrasound, which is able to pick up endometriosis better. Then, of course, the increased sexual activity and living in relationships, etc., also increase the incidence of PID producing congestive dysmenorrhea. And the first topic is when period hurts, evaluation and management of adolescent dysmenorrhea. This is going to be presented by Dr. Unnikrishnan, Director, Pratiksha Fertility Center, Kollam. He is also consultant in the Department of Reproductive Medicine, Travancore Medical College. Over to you, Dr. Unnikrishnan, for your talk. Okay. Dr. Unnikrishnan, has he joined?
Dr. Unnikrishnan. Please unmute if you are in the mute mode.
He said he had some technical problem. He'll join in 2 minutes, madam. Unnikrishnan. He's not getting access. Can somebody give?
Shall we wait or should we move on to the next session by the time Dr. Unnikrishnan gets ready?
Yes, sir. Yes, I think so.
Okay, madam.
The next one is menstrual irregularities in teens. when to investigate, and how to manage. That is going to be presented by Dr. Nisha S. Kotek. She is a consultant and head of the Department of Reproductive Medicine, KIMS Al-Shifa Super Specialty Hospital, Perindalmanna, Malappuram. So over to you, Dr. Nisha S. for your talk.
Good evening, everyone. Thanks for the kind introduction, ma'am. At the outset, I thank Kfog and Kottayam ONG Society for giving me an opportunity to present on the topic menstrual irregularities in teens, when to investigate and how to manage. Journey through teens is a roller coaster of transformation, and one of the most prominent milestones is the arrival of menstruation. However, the journey isn't always smooth, as many teenagers experience menstrual irregularities. Menstrual health is essential for the well-being and quality of life of adolescents. In the period after menarche, girls are often insecure about this new function of their body and need help if any problem occurs. At the time of puberty, there is an increase in the pulsatile secretion of GnRH from the hypothalamus, which acts on the pituitary to release LH and FSH. This acts on the ovary, and estrogen progesterone hormone brings about the changes in the puberty. So only if we know the features of normal menstrual cycle, we can identify the abnormal. The cycle length is 24 to 38 days, with a duration of 3 to 7 days of bleeding, mean menstrual blood loss 80 ml, and regularity shortest to longest variation less than 7 to 9 days. According to the ESHRE Guidelines 2023, definition of irregular cycles is a little bit different. 1 to 3 years post-menarche, it is less than 21 or more than 45 days is considered irregular. 3 years post-menarche to perimenopause, less than 21 or more than 35 days or less than 8 cycles per year. 1 year post-menarche, more than 90 days for any one cycle is considered to be irregular. So irregularity can be in the onset, frequency, duration, or volume of regular flow. The types of irregularities include heavy menstrual bleeding, oligomenorrhea, amenorrhea, and dysmenorrhea. So, as we all know, the initial 2 years after menarche, the cycles are irregular because of anovulation and immaturity of the HPO axis. So, which type of menstrual irregularities should you evaluate? Menstrual periods that have not started within 3 years of telarchy, not started by 15 years of age, even in the presence of secondary sexual characteristics, occur more frequently than every 21 days or less frequently than every 45 days, occur 90 days apart even for one cycle, last more than 7 days, require frequent pad changing, that is soaking more than 1 every 1 to 2 hours, heavy and associated with history of excessive bruising or bleeding or a family history of bleeding disorder. So we'll see one by one. Heavy menstrual bleeding. As we have already said, the initial cycles are irregular because of anovulation and immaturity of the HPO axis. But cycles typically occur every 21 to 45 days and last 7 days or fewer. Heavy menstrual bleeding is defined as excessive menstrual blood loss that interferes with a woman's physical, social, emotional, or material quality of life. It can occur alone or in combination with other symptoms. It should be classified according to the PAMCOIN system, but always keep in mind that the structural causes are less common. History taking is very important in case of adolescents because these adolescents usually cannot describe the amount of bleeding they have. So we should ask leading questions like menses lasting for more than 7 days, changing pads or tampons more often than every 1 to 2 hours, needing to change pads or tampons overnight, blood clots that are bigger than a quarter, whether there is history of staining clothing despite wearing tampon or pad. So what are the causes of heavy menstrual bleeding? Most common causes anovulation. Bleeding disorders forms the second most common cause. Other causes include endocrine like hypothyroidism, hyperprolactinemia, bleeding disorders like von Willebrand disease, thrombocytopenia, pregnancy, abortion, ectopic pregnancy, infections, cervicitis, endometritis, sexually transmitted infections, uterine pathologies like polyp, adenomyosis, leiomyoma, medications like anticoagulants, trauma, and foreign bodies. So these are some of the bleeding disorders. This is a screening tool to identify adolescents with heavy menstrual bleeding with bleeding disorder. So how to use the screening tool? If any one of the following 4 criteria are met, adolescents should undergo laboratory screening for a bleeding disorder. That is, duration of menses was 7 days or more, and the patient reported flooding or bleeding through a tampon or pad in 2 hours or less with most periods, history of treatment of anemia, family history of a diagnosed bleeding disorder, history of excessive bleeding with tooth extraction, delivery, or miscarriage or a surgery. So if any of the following 4 criteria are met, we should, this adolescents should undergo laboratory screening test for a bleeding disorder. So a detailed history should be taken, both with and without parents. With parents to know the details of the problem and without parents to know the sexual history. Since it's a subjective diagnosis, it is desirable to use an objective method of assessing blood loss, like a pictorial blood assessment chart. General examination, you should look for the signs of pallor, petechia, bruises, hirsutism, acanthosis nigricans. Abdominal examination to rule out masses and hepatosplenomegaly. Gynecological examination is not necessary unless a pregnancy-related cause is suspected. But always keep in mind, if you suspect trauma, see the local area. The frequency of bleeding disorders in general population is 1 to 2%, but bleeding disorders are found in approximately 20% of adolescent girls who present for evaluation of heavy menstrual bleeding, and in 33% of adolescent girls hospitalized for heavy menstrual bleeding. So if we suspect a bleeding disorder, we should work in coordination with a hematologist. The minimum lab investigations should include a complete blood count, peripheral smear, ferritin level, prothrombin time, and APTT, pregnancy test if she is sexually active, and thyroid and prolactin if we suspect an endocrine cause. Adolescents suspected to have bleeding disorders should undergo testing for von Willebrand disease, and the panel includes von Willebrand factor antigen and functional test for von Willebrand factor and factor VIII activity. Ultrasound actually is not mandatory, as majority of these cycles are due to anovulatory cycles. When needed, it should preferably be by the transabdominal route. And ultrasound helps us to determine the uterine causes, adnexal causes, and also to assess the thickness of the endometrium. So the goals of treatment of AUB is ensure hemodynamic stability, correct anemia, resume normal menstrual cycles, prevent recurrence, and prevent long-term complications of anovulation like infertility and endometrial cancer. Coming to the management, the first line approach is medical management. But before giving hormonal treatments, you should identify the exact cause of bleeding, why she is bleeding, and also assess the level of anemia and then start the treatment. So we can classify this as mild AUB, moderate, and severe. Mild AUB means the hemoglobin is usually 12 gram per deciliter. We can give NSAIDs and follow up her at 3-month interval with a menstrual cycle diary. Moderate AUB, we can give hormonal therapy to stabilize the endometrial proliferation and shedding with COCs or progestin-only regimens. So how will you manage a case of acute heavy menstrual bleeding? Oral progestin therapy is generally the first choice. Medroxyprogesterone 5 to 10 milligram 3 times a day, or norethistérone acetate 2.5 to 5 milligram 3 times a day. And combined oral contraceptives are the other option. So the COCs containing at least 30 microgram ethinyl estradiol to prevent breakthrough bleeding. 1 pill every 8 to 12 hours, and then you can continue with 1 pill for a total of 21 days. You can add antiemetics like 4 to 8 milligram of ondansetron if she gets nausea with high doses of estrogen. So the COCs can then be continued for 3 to 6 months. DMPA or LNG IUCD are used only in those girls who need contraception or those who cannot take pills. Now coming to severe AUB, you can classify them as hemodynamically stable and unstable. Hemodynamically stable means hemoglobin is between 8 to 10 gram per deciliter. You can use OCP, and this is similar to those with moderate bleeding. So you can give 2 doses of OCP. If she is not responding, you can even give 3 to 4 pills per day for 2 days, and then you can taper. Close monitoring and iron supplements. So if she is unstable, hospitalize her and monitor. Blood transfusion if necessary. Bleeding disorders must be ruled out before starting treatment. And the first treatment of choice is high-dose oral progestin therapy. with medroxyprogesterone 20 to 40 milligram per day or norethistron 10 to 15 milligram per day to stop an acute episode of heavy bleeding and then taper it. So what does this progesterone do? The progesterone reverses the endometrial proliferation related to long-term estrogen exposure and induces endometrial maturation. If she is not responding to 35 microgram, you can give 50. Estrogen in these OCPs also promotes rapid endometrial regrowth to cover the denuded surfaces. And then you can taper these OCPs. Tranexamic acid, aminocaproic acid, and desmopressin can be used if bleeding exceeds 24 hours, despite high-dose COCs. Active thromboembolic disease or an intrinsic risk for thrombosis are contraindications for tranexamic acid use. So, and you can even use conjugated equine estrogen 25 milligram IV every 4 to 6 hours for 24 hours if she cannot tolerate oral estrogen. If the girl is not responding to the medical management, she is hemodynamically unstable and is bleeding continuously, then we can opt for the non-medical management. Intrauterine balloon taminate, suction evacuation and suction curettage if there is a clot or a residual cast. Endometrial ablation, uterine artery embolization and hysterectomy should be considered as a last resort. Non-hormonal treatment for anemia. So anemia is also a problem. The World Health Organization defines anemia in females 12 years and older as a hemoglobin of 12 gram per deciliter, serum ferritin concentration below 50. Adolescents with this heavy menstrual bleeding are at an even higher risk of iron deficiency, with 0.4 to 0.5 milligram of iron lost with every 1 ml of blood. So we should give 60 to 120 milligram per day of iron for these girls. Now coming to the second one, amenorrhea. Primary amenorrhea is defined as having no history of menstruation by the age of 15 years in the presence of normal secondary sexual characters or within 5 years after breast development if that occurs before age of 10, according to ASRM 2024. Secondary amenorrhea is defined as absence of menses for more than or equal to 3 months in girls or women with previously regular menstrual cycles or more than or equal to 6 months in girls or women with irregular menses. So these are the causes of primary and secondary amenorrhea. Now, coming to the management, confirm normal prolactin and thyroid levels. If secondary sexual characteristics are present, then do an ultrasound. If uterus is absent, do the karyotype. 46XY means androgen insensitivity syndrome. XX means Mullerian agenesis. If uterus is present, see for the outflow obstruction. If it is present, it can be an imperforate hymen or a transverse vaginal septum. And if there is no outflow obstruction, evaluate her for secondary amenorrhea. If the secondary sexual characteristics are absent, then do a serum FSH. If it is low, it is a hypo-hypo. If it is high, it is hypergonadotropic hypogonadism. Do a karyotype. 46XX means premature ovarian failure and XO is Turner syndrome. Now coming to secondary amenorrhea, if the pregnancy test is negative, you have to do a TSH and prolactin. If both are normal, progesterone challenge test. And if she gets a withdrawal bleeding, it is normogonadotropic hypogonadism. And if there is no withdrawal bleeding, give her an estrogen followed by progesterone challenge test. And if withdrawal bleeding occurs, check her FSH and LH. If it is more than, if it is high, it is a hypergonadotropic hypogonadism. And if it is less than 5, perform MRI to evaluate for a pituitary tumor. Normal MRI means hypo-hypo. If the abnormal TSH, then it is a thyroid disease. Then prolactin is less than 100, then consider other causes. If it is more than 100, perform MRI to evaluate for prolactinoma. Negative MRI, consider other causes. A word about PCOS in adolescents. The diagnosis of PCOS in this age group is challenging as the features of PCOS overlap with the transitional characteristics from puberty to adulthood. We have the Rotterdam criteria for diagnosing PCOS. Presence of oligoanovulation or anovulation, then clinical or biochemical signs of hyperandrogenism, and ultrasound showing PCO morphology. So if any 2 of the 3 criteria are present, then we can diagnose PCOS. But according to the recent ESHRE guidelines 2023, ultrasound cannot be used for the diagnosis of PCOS in adolescents for 8 years after menarche. So in such girls, if they have any one of the features, we should consider them as at risk of PCOS. So counsel this girl and parents that they are at risk of developing PCOS, advise lifestyle modification and reassess them 8 years after menarche. The pool prevalence of PCOS among Indian adolescent girls is high, approximately 1 in 5. And we should use total and free testosterone to assess biochemical hyperandrogenism. And if it is not elevated, consider measuring androstenedione and DHEAS. AMH should not yet be used in adolescents for diagnosing PCOS. They should aim for at least 60 minutes of moderate to vigorous intensity physical activity per day, including activities that strengthen muscle and bone at least 3 times a week. So, to conclude, most of these adolescents need OP management and reassurance that their cycles would become cyclic and ovulatory over time. Treatment is required when it causes anemia or impairs quality of life. And those with non-bleeding disorder should be counseled before menarche and have a plan in place for the possibility of bleeding with menarche. Low iron stores in adolescents with heavy menstrual bleeding, reflected by low ferritin level, even with a normal hemoglobin, are associated with fatigue and decreased cognition, specifically affecting verbal learning and memory. And in those with a bleeding disorder, aspirin or NSAIDs should be used only with the recommendation of a hematologist. Anovulatory cycles are the most common cause. Confidential sexual history and pregnancy tests should be considered. Dysmenorrhea will be dealt by the next speaker. Thank you.
Thank you for a very crisp and concise presentation of a very elaborate topic and very nicely. Any queries?
Thank you.
Glad to answer.
Rani madam, you have to unmute.
Nisha, a word about lean PCO.
Lean PCO, actually, they are also at high risk of developing PCOS, and this is actually more resistant when you consider lean and obese PCOS. But this in adolescents, we should actually, we cannot tell them as PCOS. We should see both the features, like whether they are having an ovulation and also this hyperandrogenism. Only if both features are present, we should consider them as PCOS. Otherwise, consider them as at risk and advise a lifestyle modification and if necessary, COCs.
Thank you. Mohana madam, if Dr. Unnikrishnan is ready, we can.
Yes.
Has he joined?
Yes, madam.
Dr. Unnikrishnan?
Yes, joined, madam.
Joined?
Yes.
Okay. So his topic is when period hurts, evaluation and management of adolescent dysmenorrhea. He is the director, Pradiksha Fertility Center, Kollam, and consultant in the Department of Reproductive Medicine, Travancore Medical College. Over to you, Dr. Unnikrishnan.
Thank you, ma'am. Thank you so much. Thank you so much for calling me in this pride occasion. It's been my pride. And can you see my screen, ma'am?
Yes. Yes.
Yeah, thank you. So, evaluation and management of adolescent dysmenorrhea. So, I just want to tell me one patient actually came few weeks back. She is 17-year-old. She came with severe primary dysmenorrhea. It's been from 13 years of it. She's having severe pain. She went to 3 or 4 hospitals and they did trans-abdominal scan and nothing was found. And then she came to our hospital and she is 16, the pelvic examination, nothing couldn't be done except a per-abdominal examination. Asked for a, I actually counseled her for a transrectal ultrasound. Just because we haven't seen anything in our previous scans, and a transrectal ultrasound has shown a severe posterior wall adenomyoma, not that big, 2 centimeter, 2 into 3 centimeter, which was missed in almost all the scans. And from actually those cases, actually they were relieved just because they have came to a diagnosis. Now I know this is my disease, and she's been skipping schools on a period day for almost 3 or 4 years. So knowledge on these things is a must in this situations where we will be able to manage in a much better way. So dysmenorrhea is an important topic in adolescent, and so the prevalence is 16 to at high as 93%. Two types are there: primary and secondary dysmenorrhea. One second. Actually, there was some problem with my laptop I was having. Okay, ma'am. So primary dysmenorrhea is defined as a cramping pain in the lower abdomen or pelvis occurring just before or during the menstruation, the absence of other disease such as endometriosis. Is typically lasting 1 to 3 days with a negative physical examination. The secondary dysmenorrhea is usually associated with some diseases, especially at this point of time, it is endometriosis and rarely fibroids or ovarian cyst. And it accounts for the 10% of the cases of dysmenorrhea. And more than that, the 2/3 of the adolescent girls with persistent dysmenorrhea refractory to NSAIDs or hormonal therapy have endometriosis. The pathophysiology, the reason for dysmenorrhea is that at the end of the luteal phase of menstruation, the progesterone levels comes down, lysosome breakdown, more phospholipase A2 is released, which secrete prostanoids and significantly PGF2 alpha and PGE2. The PGF2 alpha constrict the arcade vessel and direct uterine contractions, causes direct uterine contraction, which causes hypoxia in the uterus and ischemic changes. The PGE2 acts on the myometrium and can cause contraction. It is often associated with GI pain, and few patients with dysmenorrhea demonstrate an increased basal tone and increased pressure in the uterus during menstruation. The risk factor: age of menarche, longer menstrual periods, heavier menstrual periods, family history of dysmenorrhea, cigarette smoking, high emotional stress play, poor mental health, poor social support, which is very significant, which we have seen with the primary dysmenorrhea when the patients usually comes and they have the mother will be scolding them and saying that it is very common in this age group, and she will be really in a tense way, and which aggravates her symptoms. So saying about the diagnosis of primary and secondary dysmenorrhea, usually we go with the history, and if the history is suggestive of a primary dysmenorrhea, that means there is the symptoms usually on the day of the periods, and which the patient will be saying it will get reduced with some NSAIDs or something, and there is no associated heavy menstrual bleeding or other patterns, then we usually say it as a primary dysmenorrhea. And with the history itself, with the history itself, we go for the empirical therapy usually. We go with the NSAIDs, or if the NSAIDs is not working, we go with the combined oral contraceptive pills. And in non-NSAIDs, the NSAIDs, how it acts, it inhibits the cycloxynate COX pathway. And the most commonly prescribed are ibuprofen, mefenamic acid, naproxen. And it is always better we start some NSAIDs on the 1 day prior, on the early morning of the periods. If she is having symptoms of periods, just start the NSAIDs even on that day. It is best given 1 day prior to the periods. And the dose of ibuprofen is 800 milligram stat and 400 milligram every 8th hourly. Mefenamic acid, you can give a stat dose of 500 milligram and 250 milligram every Q6th hourly. And if the symptoms are still persisting with the NSAIDs, then we can go for the hormonal therapy, which can be usually combined oral contraceptive pill. Even it can be norethistron acetate 5 milligram, which is said by the ACOG. Even though the FDA is not approved norethistron acetate just for the pain relief in primary dysmenorrhea, norethistron acetate can be given. Then vaginal ring subQ depot and all, which the basic thing is it suppresses the ovulation and it decreases the pain. So when a patient comes to us, go for the history if it is identified as primary or secondary dysmenorrhea, and if it is primary dysmenorrhea, treat empirically with NSAIDs or combined oral or hormonal medications. And if it is persisting, and you have to reevaluate the patient after 3 months or 6 months. And after the patient comes to you now 3 to 6 months and telling that the patient, the symptoms are persisting. And on the initial visit itself, if you're getting some clues stating that it is secondary dysmenorrhea, then you go for the other modality, which include the pelvic examination and the ultrasound pelvis. On pelvic examination in an adolescent, it is always difficult to perform a transvaginal examination. If the patient is sexually active and if the patient agrees for a pelvic examination, you can go directly with the pelvic examination, a transvaginal examination, which will give clues about the adnexal masses, endometriosis, or fibroids. Even though the pelvic examination is negative, you have to advise the patient for an ultrasound. If an ultrasound will give you more clue on the basic pathology. The surgical measures which mentioned are sacral neurectomy and uterine nerve ablation, which is not advocated in adolescents. Then after diagnosing, so after we did a transvaginal ultrasound, and now we know it is an endometriosis, then we have to, or if it is, we have to treat the secondary cause for the dysmenorrhea. So the secondary cause, which is commonly seen as endometriosis. Endometriosis, so if it is surgically found, that means if the patient is diagnosed endometriosis in an ultrasound examination, then you have to treat accordingly and individualize the treatment. The patient is having a large endometrioma, definitely go for the conservative surgery along with the hormonal medicines to make sure that it doesn't aggravate in recent time. So otherwise, if the transvaginal ultrasound is negative for endometriosis, and if the patient is still on pain and the dysmenorrhea persists, then we can ask the patient or counsel the patient for a laparoscopy. In laparoscopy, it's always difficult to diagnose adolescent endometriosis. The endometriosis will be totally different in looks and style. The vesicular lesions won't be looking like a powder burn pattern. It will be different. It will be more red in color. So we have to be very careful, and we have to see the pelvic wall and peritoneum in a much better way to identify the peritoneal deposits. And the best thing with the laparoscopy, as you know, if you are finding some lesions, you can ablate, or you can go for the surgery in that. We can corrective surgery in that setup itself, and followed by medical management. In the medical management, it is usually the combined oral contraceptive pill along with that after the surgery. GnRH agonist is usually not advocated in young age group, which has to be, which we have to think about it. And it is only given in patient with, even after the surgery, even after the hormonal contraceptive, the first line drugs, which includes COC. And if it is persisting beyond that, then you can try GnRH agonist for a period of 6 months maximum. That's what the guidelines in the ACOG 2023 is saying. Okay, so I think I have gone into the medical management and the surgical management. If any doubts, you can ask me. Thank you, ma'am.
So whether transvaginal ultrasound done routinely? No, for adolescent. At what time you will go for transvaginal ultrasounds?
Ma'am, I couldn't hear you.
So whether transvaginal ultrasound is recommended in adolescent, at what time you will think that
Transvaginal ultrasound, even in a patient with dysmenorrhea, which is not resolved with the empirical management, a transvaginal ultrasound is recommended, even with negative pelvic findings.
Because routinely we are not doing to any patient transvaginal ultrasound. That's why I asked. Anybody else will put some light on this? If they are doing. Any other questions?
Well, as Dr. Unnikrishnan pointed out, I think in severe refractory dysmenorrhea, endometriosis is a diagnosis, and high index of suspicion should be kept in cases of all cases of refractory dysmenorrhea. We have to think about endometriosis.
Yes.
That's a take-home point by Dr. Unnikrishnan.
Yes, yes.
Thank you.
Yes, thank you.
Actually, a trans-abdominal ultrasound is enough, I think, in teenagers. Because transvaginal, usually the parents will get upset. And even we can even do a transrectal ultrasound, but
That's
I
what
think it is
we-
better to
in adolescent age, what I does is always transrectal.
Rectal.
transrectal, not transvaginal. Because
Yeah,
that will have
yeah,
a
yeah,
negative
that
impact.
was my mistake. It's transrectal.
Yeah, transrectal, right.
Even the first
And-
case which I told, which was
That was also transrectal.
transrectal ultrasound.
Transrectal.
And actually, some adolescents even have big masses. We might miss it because we are not doing a pelvic,
Transabdominal.
when we are not doing a PV. So we may miss the masses. In fact, one of my nieces, severe dysmenorrhea, we used to give tablets and all that. Finally, when we did a scan, we found a huge fibroid, and that had to be removed by laparoscopy. And after that, after she got married and all, she conceived normally, had a baby. So actually, we should not just say, oh, that is the usual thing, you just bear. We should always investigate, and only if there is nothing else, we can ask them to have some lighter painkillers, etc.
Yes, madam.
And and in during the surgery also, ma'am, one patient we did, she was present with severe dysmenorrhea. Vaginal scan was negative, means pelvic scan was negative. Then we went for the laparoscopy after telling the parents. And during the laparoscopy, what we see is very small vesicular lesions in the peritoneum, in the paraovarian.
Yes.
Even the small lesions causes severe pain in these patients.
Exactly.
And it is usually because of the more of aromatase activity and more of prostaglandins are released in these small lesions.
So first we have to rule out all these physical problems actually, and then only prescribe. Another thing is, I find that workout and exercise will decrease the dysmenorrhea to a great extent. Almost every adolescent class where I go to, I show 2 or 3 slides of mild exercises.
The turmeric powder, everything works, madam, in the primary dysmenorrhea.
Yeah, but workout does help, and also it regulates the periods also.
Okay, if there are no more questions, we'll pass on to the next speaker. Mohana madam.
One point I wanted to add, that is in our olden days, one of the questions in MD is what is the indication for PR in gynecology? So we have to tell that it is unmarried person. Many a time by PR we can find out uterosacral thickening, some masses in the pelvis. Those days there was no ultrasound.
Yeah, madam.
So just I wanted to add that point.
Madam, we're still doing in medical college, madam, PR examination.
Clinically, we can have a suspicion and then send her for scan. Otherwise, if it was okay, I mean, even absent uterus we can detect because hooking the uterosacral ligament by your index finger. If there is nothing in between, then it is Rokitansky. I mean, absent uterus and all that. So those were the days when there was no ultrasound. So let us move on to the next one. That is HPV vaccination in clinical practice by Dr. Anila Azad. She is presenting as FAQs for consultants. Dr. Anila Azad is a consultant in obstetrics and gynecology department. She is working in Lifeline Hospital, Adur. Over to you, Madam Dr. Anila Azad.
Good evening, madam. Am I audible?
Yes. Yes, Anila, you are audible.
Okay, madam. respected madams, sirs, and dear colleagues. Thank you, madam, for the introduction. And I take this opportunity to thank Kfog and Adolescent Health Committee for giving me an opportunity to give a talk on HPV vaccination in clinical practice, FAQs for consultants. To begin with, let's have a brief introduction about human papillomavirus and the types. HPV, there are high-risk group, including 16, 18, 31, 33, 45, 52, 58, among which HPV 16 and 18 causes more than 75% of cervical cancer. There are non-cancer causing types, low-risk group including 6 and 11, which is responsible for anogenital warts. So HPV-induced cancers, almost 100% of the cervical cancers, vaginal cancer, vulvar cancer, penile cancer in men, oropharyngeal cancers, anal cancer, and non-cancerous lesions like genital warts are caused by HPV. What is the cervical cancer disease burden? It is the fourth most prevalent cancer among women worldwide. It is the fourth leading cause of cancer mortality in women globally. In India, cervical cancer ranks as the second most common cancer in both incidence and cancer mortality among women. India harbors about 20% of the cervical cancer cases in the world, and nearly the mortality is around 23% in India due to cervical cancer. So what is the prognosis of HPV infection? 70% of the infections get cleared in first year, another 20% is cleared in the next year. Persistent HPV infection causes cancer. It takes around 5 years, 10 years to 20 years for progression from HPV infection, low-grade lesion to high-grade lesion and invasive cancer. So HPV vaccination forms the basis of cancer control. It is a primary prevention, and screening and treatment being the secondary prevention of precancerous lesions. So what is the rationale for vaccination? Natural infection will lead to weak antibody response, whereas vaccination produces high antibody response. Higher antibody level at cervical epithelium prevents HPV infection. So the development of HPV vaccine, it is formed by HPV surface components called as virus-like particles of the L1 protein in cultured cells and formulated with adjuvants to increase their immunogenicity. It is not infectious as they lack viral DNA. VLPs are strongly immunogenic. Neutralizing antibody is sufficient for protection against viral challenge specific to HPV type. So this is the figure of a capsid protein L1, and from which the VLPs or viral-like particles are produced. So what are the available HPV vaccines? We have bivalent and quadrivalent vaccines. Cervarix is a bivalent vaccine harboring HPV 16 and 18. Cicolin is another bivalent vaccine which is available in China. We have two quadrivalent vaccines, Gardasil and Cervavac. Cervavac being produced by Serum Institute of India and the Indian government's Department of Biotechnology. It gives protection against HPV types 16, 18, 6, and 11. Non-valent vaccine called Gardasil 9 is also available. It has 16, 18, 31, 33, 45, 52, 58, 6, and 11. So it gives protection against 9 types of HPV. Coming to the dosing schedule, the preferred target age group is 9 to 14 years. The number of doses required is 2 doses, 0 to 6 months apart. If the girls aging 9 to 14 years are immunocompromised or infected with HIV, then 3 doses are recommended. If bivalent vaccine, 0, 1, 6 months, and for quadrivalent vaccines, 0 to 6 months. Catch-up vaccination is recommended up to 26 years of age. 3 doses are recommended, 0, 1, 6 months for bivalent and 0 to 6 months for quadrivalent. Similar recommendation is for older age group from 26 to 45 years of age. And in both these categories, girls or women who have been sexually active should be counseled regarding the reduced efficacy and also counseled regarding the importance of screening. What is the mode of administration? It is given intramuscularly in the deltoid region of the upper arm or in the higher anterolateral area of the thigh. Should not be administered intravenously, intradermally, or subcutaneously. Coming to the contraindications and side effects, severe allergic reaction to any vaccine component or following a prior dose of HPV vaccine is a contraindication. Side effects are usually mild, including injection site pain and redness and mild fever. How to store HPV vaccines? Should be maintained at 2 to 8 degrees Celsius, not frozen and protected from light, and should be administered as soon as possible after being removed from the refrigerator. How long does the protection last? Continued protection and persistent antibody levels present a minimum of 10 years following vaccination. There is no evidence to suggest that a booster dose is needed. What if vaccine schedule is interrupted? There is no need to restart vaccine schedule when second or third dose is delayed. There is no recommendation for maximum interval between 2 doses, but it is advised to complete vaccination schedule within a period of not more than 12 to 15 months. Can HPV vaccines co-administered with other vaccines? Yes, HPV vaccines can be safely administered with other age-appropriate vaccines using a separate syringe and at different sites. Are HPV vaccines interchangeable? HPV vaccines have different characteristics and components. Efforts should be made to administer the same vaccine for all doses. However, if the vaccine used prior dose is unknown or unavailable, any HPV vaccine can be administered to complete the recommended schedule. Will it be better to wait and vaccinate girls when they are older? No, it is not recommended to wait till they are older than more than 9 to 14 years of age, because vaccine produces a stronger immune response at a younger age, and it is most effective before a person comes in contact with the target HPV types. The most prevalent among HPV is most prevalent among young women less than 25 years of age if they become sexually active. So it is advised to vaccinate between 9 to 14 years of age. In fact, CDC recommends the age of vaccination as 11 to 12 years of age. Again, 2 doses, 0 to 6 months apart. Can HPV vaccination be done in older age group? Yes, vaccination can be done up to 45 years of age, but here the priority should be given to cervical cancer screening. Prior to vaccinating, counseling should be done about the reduced efficacy of the vaccine. Is vaccine effective in sexually active females? The protection is strongest for the HPV types that a person has not yet been exposed to. So to benefit fully from the vaccine, it is best to be vaccinated before initiating sexual activity. Can HPV vaccine given to women with abnormal pap smear or a positive HPV test or previous HPV lesions? Yes, they can be vaccinated, but it should be counseled about the lack of any therapeutic effects on the existing pathology and reduced efficacy of the vaccine in older women. The chance of a woman being infected with all 4 types of HPV in a quadrivalent HPV vaccine is very low. It is around 0.1% only. So even if the woman is infected with one or the other type of HPV, they can be given vaccine so that it gives protection against the types to which the woman is not infected. HPV vaccination in victims of sexual abuse and in HIV infection. Sexual assault survivors should be given 3 doses of HPV vaccine with the first dose at the time of initial examination. HIV positive girls should be advised to start HPV vaccination from 9 to 14 years and should be prescribed a 3-dose schedule. Is HPV vaccine safe during pregnancy and lactation? It is not recommended in pregnancy, but if the patient becomes pregnant after initiating the HPV vaccination, termination is not required. Further vaccination should be withheld and the remaining doses given post-delivery. Lactation is not a contraindication for HPV vaccination. Should boys be vaccinated? Both the nonavalent and quadrivalent vaccines are licensed for the use in boys as well. It gives protection against anal, penile cancers and also genital warts. But due to global shortage of the HPV vaccines, WHO recommends vaccination of girls as a first target. So there is a global strategy initiated by WHO, which we can eliminate cervical cancer as a public health problem through intensified vaccination, screening, and treatment. It is a 90-70-90% approach. where the target is to achieve 90% of girls fully vaccinated with HPV vaccine by the age of 15 years. 70% of women are screened with a high performance test by 35 years of age and again by 45 years. And 90% of women identified with the cervical disease receive the treatment. In Indian scenario, less than 1%, of the women, girls are vaccinated with HPV, and less than 3% are screened for the cervical cancer. What are the challenges in HPV vaccination? It is expensive, multi-dose schedule, shortage of vaccine supply, and it is not included in current vaccination programs. So what can be the future roadmap for HPV vaccine? To incorporate HPV vaccine in national and school immunization programs, create awareness among the eligible women and girls for vaccination and screening. Nonavalent vaccine can provide wider coverage than quadrivalent vaccine. Single-dose vaccination may also be considered in the future. There is strong growing evidence that the effect of a single dose is similar to 3-dose and 2-dose schedules. There are results from cohort studies like IARC India trial with a quadrivalent vaccine and Costa Rica trial with a bivalent vaccine, showing comparable efficacy between single-dose and multi-dose schedules with sustained antibody levels for at least 11 years after vaccination. There are also evidences from Kenshi and Doris trials regarding single-dose vaccine. So a take-home message. So we have bivalent, Cervarix, quadrivalent, Cervavac, and Gardasil. I think nonavalent is also getting available in India. And it is licensed to use in India from 9 to 45 years of age. The target age group being 9 to 14 years. And 2 doses is recommended, 0 to 6 months apart. If immunocompromised or HIV infected, 3 doses are recommended. Catch-up vaccination from 15 to 26 years and up to 45 years, 3 doses are given. 3 doses, 0, 1, 6 months if bivalent and 0 to 6 months if quadrivalent. And for interrupted causes, continue with the remaining dose as per the age-based recommendation. The vaccine series should not be restarted. Pregnancy and lactation not recommended in pregnancy, but no need for MTP. Can be given during lactation. For the victims of sexual abuse, 9 to 14 years, same age recommendation, 3 doses with the first dose given at the time of examination. And women with a history of abnormal screening reports should be, vaccination can be given 3 doses, but should be counseled regarding reduced efficacy and the importance of regular follow-up. In the future, mass single dose of nonavalent HPV vaccination for sexually naive pre-adolescent girls can provide almost 100% protection and a cost-effective approach for the developing countries towards elimination of HPV infection and hence cervical cancer. Thank you.
Thank you, Dr. Anila, for your crystal clear presentation. And you have not left any stone unturned. I thought you would forget about the boys, and you included that also.
Thank you.
So it is open for discussion.
Most common question by general public is whether there is any problem in getting pregnant after getting this injection. That is the question most of the time the general public asks. So we have to counsel about that also to the parents. That is the only thing. And I think Dr. Anila could cover everything. Thank you. Thanks a lot. And I want to thank Dr. Mohana Madam for being chairperson for all the first 3 sessions. And Dr. Unikrishnan, Dr. Nisha, and Dr. Anila did very well. And they presented well. And I think we can move to the next session. Any questions?
Actually, during adolescent classes, I tell the girls, for your next birthday, you ask your parents, not for a new dress or not for some jewelry, you ask for a HPV vaccine, which will protect you from cervical cancer for your entire life. I think it's very important that we tell them, it's not that costly, but it will be the biggest gift that a girl can get. And Dr. Anila, your presentation was super.
Thank you, madam. Thank you so much.
So we'll move to the next session now. Dr. Dempsey is here. So we will go for this panel discussion now. The topic is building a teen-friendly OPD, whether it's a myth, any mistakes, and what can be done. And Dr. Dempsey, she is here.
Yes, ma'am.
Dr. Dempsey is from, she's an assistant professor in SAT, and she works in Government Medical College, Trivandrum, and her special interest is, area of interest is high-risk obstetrics. And I really appreciate Dr. Dempsey, madam, for this immediate response when I asked her whether she'll do the panel. And within few hours, she came with so many appropriate questions. And I thank both the Trivandrum Society and Alappuzha Society for creating this panel very immediately and in very short period. Over to you, madam. Dempsey, madam.
Thank you so much, madam. Thank you so much for the nice introduction. So our topic is on building a teen-friendly. I think the screen is visible.
Yes, you are visible,
Okay.
but
Screen is not visible, ma'am?
whether you're sharing the screen now?
Yes, ma'am. I will try once more. Now, is it visible, ma'am?
Actually, it is blank. You can see the screen, but it's blank.
Coming now.
Yes, we can see.
Okay, okay. So our topic is on building a teen-friendly gynecology OPD, myths associated with mistakes and must-dos. So before jumping into the panel discussion, I would like to thank Kfog and respected organizers for giving this opportunity. Definitely, it's an honor and privilege to moderate this panel discussion. So let me introduce our panelists. Dr. Bhavani L. Nair, who is currently working as Associate Professor, Obstetric and Gynecology, Sri Gogula Medical College Research Foundation. Dr. Neena Ananthan, who is currently working as Consultant Gynecologist, Kinder Hospital, Cherthala. Dr. Fiji Raj, Junior Consultant, working at a Women's and Children Hospital, Pujapura, Tirunelveli. Dr. Nitas, who is working as Senior Resident at ACT Hospital, Government Medical College, Trivandrum. And Dr. B.S. Ahalya, Senior Resident, Obstetric and Gynecology, Government TD, Vandana Medical College, Alappuzha. And the youngest one, Dr. Aishwarya A. Mohan, Junior Resident, SAT Hospital, Government Medical College, Trivandrum. So first of all, let us understand what is adolescence. We all know that adolescence is a period that spans between 10 to 19 years, and it is an important transition from childhood to adulthood. So before the proper panel discussion, I would like to highlight a unique strength of our panel. We have diverse age group of experts, including younger panelists like Aishwarya, who recently navigated the adolescent period. So I'm sure that this blend of age group will undoubtedly enrich our discussion regarding teen-friendly OPD and will definitely debunk the myths associated with it. Okay, so we already told that the adolescent period spans between 10 to 19 years according to WHO, and it's an unique stage where there is development, and it is an important time period for laying foundations for good health, which will result in rewarding life ahead. So we all know that for laying foundation, what adolescents need is proper information and education. And there comes our role as gynecologists, and it becomes an incredible asset, the knowledge, our knowledge to impart them. So we have to give adolescents the critical information about their growth, their healthy habits, and also it is very important to make them aware about the cycles, the hormones, and the very important thing, the mental health during hormonal changes, etc. And certainly there are benefits for gynecological visits. We can make them empowered to prioritize their reproductive health by addressing conditions like menstrual irregularities, which can cause confusion and anxiety. Definitely there will be mood swings, body image issues, we can address that. And it is very important to give information about sexual health and contraception. And we all know that there are various cultural stigma existing in our society. And I would like to reveal my own. Looking back, I recall my own struggles with menstrual irregularities after menarche. And definitely my mother was influenced by social myths and she hesitated to take me to gynecologist. And as a result, actually, I suffered in silence. There was anxiety, fear, etc. The thing is that actually I even believed that I had a cancer due to this irregular bleeding. And sometimes there will be thoughts like I will be able to have children in the future, etc. So reflecting on these experience, I realized that the immense pressure and misconceptions many adolescents girls facing. So eminent persons like Sujitra Madam are motivating all of us to advocate for better support and educations. That is very happy, ma'am. So we can go jump into our topic. We all know that there are many myths existing in our society. So, Dr. Fiji, can you tell me what are the common myths existing in our society and how can we dispel that myths?
Yes, Dr.
Dr.
Nancy. Good evening, all. First of all, let me thank you, thank you the Kfog and the organizers for letting me be a part of this panel discussion, and especially thanks to Dr. Nancy for inviting me for this panel discussion. Coming to the first myth, the greatest myth regarding a teenager visiting a gynecological OP is that people consider them that they are sexually active teens. Uh, Earlier on, if a young girl visits a gynecologist, people would be raising eyebrows, questioning the moral side of the girl, and raising suspicions whether the girl is pregnant or not. But nowadays, time has actually changed, and like Dr. Dempsey said, now people, if they are having menstrual complaints, the mothers bring their daughters to our OPD much easily. But still, this care is not only for sexually active teens. Regardless of all whether they are active sexually or not, all teens need to address their menstrual issues, their puberty concerns, and also they have to get an health education regarding their preventive care. So having an important means the importance of an early education and giving them an awareness about their reproductive health is very important. The second myth is that unless the teens don't need gynecological care unless they have symptoms. Routine gynecological checkup has not become a part of our health system, but it should be encouraged since it helps to prevent health issues, detect problems early, and to promote healthy habits. Annual visits can provide an opportunity for education, screening, and as well as counseling. Another myth is that the gynecological examinations are painful and traumatic. Many of the girls would not have attended a gynecology clinic or attended a gynecologist. Their information regarding a visit to a gynecologist would naturally be from their elder sisters or cousin sisters who would have had their first vaginal examination during their pregnancy and in labor. Naturally, it's painful. So they get the impression that once you go to a gynecologist, they will torture you. But in fact, most gynecological examinations for teens are routine, gentle, and they give only just minimal discomfort. We try to gain the trust of the teens, and we ask a consent before undressing them. We permit the presence of their trusted adult during their examination. We are actually trained to make the teens feel comfortable and relaxed during examinations. And as it has been discussed during the classes, we usually do not do a pervaginal examination. And in cases like torsion, when we suspect a mass, we resort to perrectal examination. But now, since if the teens are sexually active and due to the usage of menstrual cups, if the teens are giving consent, we can resort to per vaginal examination if needed, but it's not mandatory. Coming to the next point, one of the major reasons why, most common reasons why the teenagers attend the gynecological clinic is that they consider that irregular periods are always sign of serious problem. As Dr. Dempsey said, initially the irregular cycles are a part of our life and it is normal, but everyone is very much anxious about that. But it's a fact that not everyone has a 28-day cycle. Cycle between 21 days to 35 days are normal. And infrequent cycles are not much to worry. At least one cycle in 60 days is normal, provided the bleeding is not heavy. And irregular cycles are normal during the first 2 years after menarche. Irregular periods can be caused by various normal factors like stress, diet changes, exercise. But we should always rule out problems like PCOS, thyroid disorders. And so it's better to consult a gynecologist when you have irregular periods, mainly if infrequent cycles are normal only, as long as bleeding is not heavy. But we should rule out other causes. Next myth. Another thing is that many teenagers actually come to our OP with anemia. That is because even if they have prolonged bleeding, the parents, there's a layman talk that heavy cycles are normal during the menarche initial years as well as during the perimenopause lead. Yeah, there'll be irregular cycles, and following that, bleeding, they start bleeding profusely and continuously, and the people say that they have not had cycles for 3 months, so all the blood, dirty blood has to go. So finally, they present with anemia. So irregular cycles are okay, but as long as they are not associated with heavy cycles, it is fine. But heavy cycles should always be evaluated, and or else it leads to anemia. Another common misconception is regarding vaginal discharge. Vaginal discharge is always seen as a sign of infection. Vaginal discharge is normal and can vary in color and consistency throughout the menstrual cycle. Only if the discharge is having a foul smell, itching, or is associated with abdominal pain, we need treatment, and this should be evaluated by a gynecologist. And another misconception is that most of the mothers who accompany their daughters to the gyneco OPD says that my daughter is not putting on weight because she has excessive vaginal discharge. Actually, it's a very wrong conception, and vaginal discharge is not in any way related to our body weight. One of the reasons why the teenagers are reluctant to come to the gynecologist is that gynecologists are judgmental about teen sexual activity. Fact is that gynecologists are actually trained to provide confidential, non-judgmental care to teens. Their goal is to support teens' health and well-being and not to lecture or judge, but it remains a fact that we have a role in providing them counseling regarding safe sexual practice, sexual hygiene, so as to avoid problems like sexually transmitted disease as well as teenage pregnancies. So, to promote a teen-friendly gyne clinic, we need to dispel myths through education. Providing accurate information about gynecology care and reproductive health is very much important for building up a very healthy generation. We should encourage open and honest communication between teens, parents, and healthcare providers. We also should be able to offer resources and support for teens to make informed decisions about their health. Coming to the key points, gynecological care is essential for all teens regardless of sexual activity. Regular checkups can promote healthy habits and detect problems early. Healthcare providers are trained to provide confidential, non-judgmental care. Thank you.
Thank you, madam. I think madam had covered all the myths and the ways to break it. So, Dr. Aishwarya, I would like to know from you, you are the youngest panel member. So I would like to know what are the strategies that can be created to make a gynecology OPD more teen friendly.
Am I audible?
Yes, yes.
Good evening, all. Thank you, Densi Madam, for the introduction. So before I begin, I would like to express my sincere gratitude towards the entire team for giving me such an opportunity. So coming to the question, so to pull out these teens out of all these myths and to bring them to their healthcare facility, we should have some strategies for creating a teen-friendly gynec OPDs. And these can be mainly discussed in 7 main domains. So whenever a teen attends an OPD, how should the OPD be? That is the first domain, that is the desired infrastructure. How should it be? So we can say that a desired infrastructure should be such that it should have separate rooms, and if at all a room is not possible, preferably separate cabins to get adequate privacy. And the environment should be such that it is teen friendly, that is including the awareness such that it includes teen friendly images, posters, audio visuals, or short films which can create awareness as well as it is teen friendly. Then there should be basic amenities like proper seating arrangement, there should be proper waiting areas and clean drinking water, sanitary facility, and proper signages. So coming to the next domain, what are the basic human resources that we need in a teen-friendly adolescent clinic? So that is, we need a medical officer, staff nurse, an adolescent counselor, and also a security as well as a receptionist. And the special mention is all these staff should be an adolescent-friendly health service provided, trained. And regarding the MOs, it is preferable to have female MOs and preferably 2 in number. Next domain is the timing and affordability. So what should be the timing of these clinics? Yes, it should be preferred in the local teen adolescent, the local teen timing, that is like a weekends or after school hours. And we should encourage not just prior appointment, but also walk-in consultations. And whatever facility we provide should be affordable for the local teen. Coming to the next and the most important, that is treatment with dignity and respect. So we should know, and this is the most important aspect and the most trained aspect of the adolescent friendly health clinic training session, where each and every staff is sensitized for a proper, respectful, empathetic, and a non-judgmental communication. We can imagine whenever a teen enters a clinic, even a judgmental look can make them uncomfortable with the surroundings and may make them walk away from all these services. So every time such a communication, we know everything begins with a good rapport. So rapport building can be with the help of open-ended welcome the child with a smile in your face. Ask them unrelated or say some general questions or casual questions, and then come to more sensitive questions. And the questions should be open-ended, and make sure we don't use any medical abbreviations or jargons, and the questions should be age appropriate, or the words should be age appropriate. So the next aspect is again the very important aspect, that is regarding the privacy and confidentiality. And this must be entrusted among the teen group so as to make them comfortable and encourage more and more such consultations. And by privacy, we mean simple things like asking them a consent before examining them or before undressing them, and giving them adequate privacy when we are doing an examination, like putting proper covers or putting curtains, or closing the doors and windows in the presence of a staff nurse. These are the basic privacy policies we can adopt. And next, regarding confidentiality, again, it should be secured, and we should ensure and entrust them that none of the details will be shared without prior consent, except in the case of any court liabilities. Next thing is again an extension, that is how to improve this. We have to make outreach and awareness programs, that is collaborating with the schools and colleges. We can again create more and more awareness and early referral, and we can make use of the current social medias like Facebook, Instagrams for sharing the health related tips and improve our services. Finally, the last domain, but it is the hope for the future, that is quality assurance. And this can be made with the help of anonymous feedback forms, in which the teen can provide their own effort, their own ideas regarding improving our services, as well as adequate staff training at regular intervals to keep ourselves updated so as to provide a better adolescent practice. So these are the basic things or strategies for creating an adolescent-friendly gynec OPD. Thank you, madam.
Thank you so much, Aishwarya. It was very crisp and clear. And I really appreciate your effort to make awareness in the school kids, adolescent kids regarding all these things. And now I want Dr. Nita. Dr. Nita, we all know that there are a lot of trust issues with teen patients. So can you tell me how can we build the trust with such teen patients?
Okay, good evening all, and thank you, madam, for this question. So the question was, how can we as healthcare providers build trust with teen patients? So as we all know, trust is a fundamental aspect of the relationship between an adolescent and the healthcare provider. So a welcoming, non-judgmental and supportive environment for an adolescent patient helps us to build trust with them. Building trust is important because trust has an essential role in adherence to prescribed treatment. It is important to build trust with them in the initial visit itself, as the adherence to treatment and further follow-up depends on the first visit itself. The first gynecology visit for a teen is usually anxiety-filled. Let us see some examples on how we can do this. The initial interview should be conducted confidentially and with the teen fully clothed. Another one strategy for this is to schedule teens in a special office time and instruct the staffs not to interrupt. According to some studies, authors use one afternoon per week exclusively for teens. This usually allows them to meet other teens, which will help them relieve their anxiety issues. Brochures can be provided to each teen at their first visit, and a business card with the office phone number can also be included, and the teen is encouraged to call with questions and problems. The next one is engaging in small talks. So building trust through respectful communication, acknowledging their concerns, and involving teenagers in decision making can foster effective communication and thus encourage active participation in their healthcare. The studies actually show authors usually asking the teens about the school activities and their friends. This easily allows us to access the maturity and the peer group influences. This line of questioning also helps providers access the knowledge about the teen and provide accordingly. Next one is confidentiality. So confidentiality was reported most often by adolescents as a defining characteristic of trust of the healthcare providers. According to a study conducted by McKee and Fletcher in 2006 in the United States, older girls were more likely to report experiencing confidential care. Hence, we should create a safe and confidential environment, assuring the teenagers that their information will be kept private will help in building trust among them. Let's see some examples regarding this also. The teen and the mother are told that the patient's chart is confidential, although it is made clear that the confidentiality does not extend to life-threatening behaviors. The mother can be excluded or excused from the room, and questions about sexual activity and other risk-taking behaviors are asked in private. Some teens want their mother, or maybe do not want their mothers in the room during the physical examination. Then the teen is asked about this in private. This helps the teen express her true wishes without the fear of hurting her mother's feelings. Next is being trustworthy and honest. According to a study conducted in Netherlands, chronically ill adolescents stated that being trustworthy and honest with them was one among the most desired quality that they wanted. And honesty was also identified as a building block of trust and meant telling the truth and not withholding the information. Next one is listening to them. Older adolescents had a stronger preference for staff being focused on them rather than their parents and listening to them. So we have to remember not to lecture and try to limit explanations to a minute or less. This can be hard to do when explaining a complex situation such as premature ovarian failure, but it can apply to most of the situations. The last one is empathy. So empathy is defined as the ability to understand and share the feelings of one another. Once we stand on their shoes and understand how they feel, we will be able to be like one of their dear ones, and they'll be able to build trust with us. So there is a data from AZOG which says that be relaxed, make eye contact, be genuine, friendly and open, demonstrate respect and positive regard, be interested in the patient's needs, questions and activities, address the confidentiality issues, inquire about the patient's concern, understand that full trust may take time, be an authority, not an authoritarian, be non-judgmental, and ask the hard questions. Thank you.
Thank you so much, Anita, for sharing lots of insights. And I welcome Dr. B.S. Ahalya Doctor, can you tell me what are essential services we should provide in a teen-friendly gynecology OPD?
Good evening, all. I hope I'm audible.
Yes. Yeah.
Thank you, madam, for this opportunity. And coming on to the question, my part is to discuss on the essential services to be provided in a teen-friendly gynecology OPD. I'd like to start from the counseling part. Youth clients seeking sexual and reproductive health services approach health facilities with great nervousness. They're unlikely to honestly share their concerns at once. We have to earn their trust, and we might start from the counseling part. A comprehensive and integrated counseling on required areas. It should be individualized to each of the patient that is coming to you. They might need information regarding puberty, menarche. They may be curious about nightfall and sexual attraction, masturbation, violence, especially gender-based violence and intimate partner violence, conception, contraception, abortion, safe sex practices, and if not, sexually transmitted diseases as well. If the young client is seeking a pregnancy test, provide information on the pregnancy testing and use this as an opportunity to give them information regarding contraception and abortion. It may be difficult to earn their trust, exercise patience, and drop sufficiently so that the actual problem of the client can be understood. It is important that we have to earn their trust and give the best. The next part is the mental health and hygiene management. Address various myths and misconceptions around menstrual taboos that restrict their movement, the menstrual hygiene, education, and other activities and health during menstruation. We have to create awareness about menstruation. They have to be provided information regarding where they can access and use sanitary pads, and also the other methods like the menstrual cups and how they has to be used and how to dispose them as well. They have to be told that puberty is a time of growth spurt, body changes, and onset of menarche is a normal physiological change as well. Provide treatment for irregular period and menstrual problems as well. The next part is the provision of contraception. Provide a full range of contraceptive options, and the age or being an adolescent should not be a restriction to provide any type of contraception. All the types, including the condoms, emergency contraceptive pills, injectables, oral pills, has to be provided, and the cafeteria method has to be provided even to the adolescent group. Emphasis should also be placed on encouraging the male participation where it is possible. The next part, if you're providing contraception, it's important that these people should also be given information regarding safe abortion services as well. Because adolescence is a period when they are going to be curious enough, they are going to have the sexual arousal, and they may be experimental with their body, and they may even end up being pregnant, which is unwanted. Ensure that young women are able to avail safe abortion under the MPP Act. If they are minor, go on with the registration of the POXO, collection of samples, and also because it is a statutory rape in case of a minor, we have to go on legally as well. A guardian can be any person who is major and should be there for the consent in case it is a minor. And if at all the patient presents you as pregnant in the later part of the pregnancy and wants to deliver, maternal and health related services has to be provided. All facilities should offer maternal health services in a non-judgmental manner to the young teenage girls and women irrespective of marital status. Respectful along with evidence-based maternity care should also be provided. And because these adolescent girls are more prone to develop sexually transmitted diseases because of unsafe sex practices, this should also be addressed. Integrated screening for sexually transmitted diseases has to be done. And this is the one part which is the syndromic approach. I've added this in order to make the concern about the last part, which is a recent addition. That is a kit 8, which is a brown kit for anorectal discharge syndrome. The rest is non-TOA. The next part is diagnosis and management of other sexual and reproductive health issues, early detection of pregnancy, menstrual disturbances, and hirsutism. These girls would more be concerned about their appearance. There is obesity and hirsutism, which is associated with the polycystic ovarian disease, and not more of the irregular menstrual cycles. This should also be addressed. Then coming to the care of survivors of violence, this may be one of the part which we are not that concerned right now. Cases of violence, including rape, domestic violence, intimate partner violence, and sexual abuse are usually undisclosed. Instances of violence can be physical, mental, sexual, or emotional in nature, and it is important that all providers are sensitive to these issues and are oriented on law. The first step is to offer medical services, and then the next one is mandatory reporting and informing the client and connecting them to a support NGO. Then it's a mental health, that is interconnection of sexual reproductive health and mental health. Mental health problems remain a widely unaddressed issue at large. They could be linked to various social barriers, educational attainment, personal relations, or health issues such as unwanted pregnancy. We have to identify the mental health needs, identify the symptom, and make proper referral to specialists. That's all.
Thank you so much, Ahalya. Thank you for shortening such a vast area. And now we move on. Dr. Bhavani, can you tell me how can we involve teens for designing, and how can we, by involving them, how can we improve our services?
Good evening, everyone. Thank you, Densi, for the question. So, involving teens in the design and improvement of gynecology services is crucial to ensure that these services are accessible, comfortable, and meet their unique needs. So, we can form youth advisory boards by including the active adolescents, and so that they can provide the feedback and insights on the gynecology services that they need. Then surveys can be conducted to gather opinions and gather the experiences of the adolescents who visit the clinics, and also focus groups can be formed by including the adolescents. Then participatory design workshops can be conducted so that the teens can co-design and provide input on the service that can be provided and to improve the services. Then we know that it is a tech-savvy generation coming up. So online forums and social media are important to gather the feedback and suggestions. Then collaborating with schools, the school health talks, they are very important. As already said, school health talks, we can give the sexual and reproductive health talks, and also we can also get a feedback on the gynecological services. Then not to forget the college going students also, we have to train the adolescents there about the sexual and reproductive health and the menstrual health also. Then we have to build a inclusive and youth friendly facility so that it will be welcoming, as already mentioned by the previous speakers. It should be welcoming. The knowledge that we get and the information that we get should be kept confidential, and the facility should be well equipped so as to solve the problems of the adolescents. So by involving the teens in the design and improvement, the healthcare providers can create more effective youth-friendly gynecology services that cater to the specific needs and concerns. Thank you, Densi.
Thank you so much, madam. I think this is the main area we have to focus to improve the adolescent gynecological care. And I really appreciate madam for involving in awareness classes for adolescent. Thank you, madam. So next we come, we know that there are many potential challenges, and definitely there will be solutions. So Dr. Neena Anandan, madam, so can you tell me some, what are the potential challenges and what are the solutions that can be implemented for adolescent clinic?
Thank you, Dr. Densi, for the question. Good evening, everyone. Actually, anybody like me who has raised a teen or an adolescent will agree that dealing with adolescents is really challenging. And implementing clinics solely for adolescents also has got to be filled with challenges. But almost everything has been dealt with by my previous speakers. So I will just probably be summing up some of the salient points. I hope I'm audible.
Yes, ma'am.
Okay. So, one of the basic problems is that we do not have enough facilities as of now. A clinic that is specifically designated to taking care of adolescents. It's probably because the concept of an adolescent clinic as such is a kind of novel thing for us gynecologists and the community as such. So why we don't have enough services that are accessible to these teens? Maybe because in the private and the public sector, there is not adequate funding towards these clinics. In the public sector, probably there are more so-called prioritized health problems. In the private sector, these adolescent clinics may not be an income-generating area. So what we should do is create awareness initially among the lawmakers and the bureaucrats as to the importance of adolescent health. Adolescents are our future, so their care should be prioritized, and there should be funding for more funding towards this area. In the private sector also, it can be run using public grants or with the help of NGOs. Another problem is that most of these kids are either in school or college and one of the busiest times of their lives. So they don't have access, they may not have a clinic running next to them where they can go to. Even if there is, the timing may not be suitable for them. So we have to find a solution. We can try partnering with schools and colleges, have outreach camps. We can actually go to them rather than them coming to us. So we can have mobile clinics. Another strategy could be to have online consultations or evening clinics or holiday clinics where they can actually, it might be easier for them to access. Another problem that we face is that we don't have adequately trained staff or the infrastructure to run these services. Because it is not just the medical care that is needed. We need to have people who actually know how to speak to adolescents. So there should be adequate emphasis given during the UG in the UG and PG curriculum to focus on adolescent health, including their mental health and how to communicate to the adolescents. And we should pick up staff who have the interest and the aptitude in dealing with these children and train them and have it bring up a team which can actually run these services. We not only need doctors and nurses, but we need mental health people who can help them with their mental health problems. So we need a whole team which have to run together. Another thing is many of these children are nowadays very fiercely independent. They don't want to come to the clinic with their parents. They have so many things private from them. So some of them can't afford to come. So it might be a good idea to provide free clinics in the public sector and subsidized treatment in the private sector. Another problem is that these teens have a lot of problems, but they are not aware that there are places where they can actually go and solve them. So we should actually go out to these schools and colleges with outreach programs and make them aware where they need to go to take help. And also these clinics should be advertised in teen-friendly platforms like Instagram and such. Another thing is, we all know teens are not very trusting. It's very difficult to get them to trust you, and they will not believe that you will actually cater to their confidentiality and privacy. They may need privacy even from their parents and guardians. So there should be proper policies and procedures written down, which to which they also have access. And staff should also be trained adequately to adhere to these procedures, and there should be a proper training for the staff for communication, so that they are non-judgmental and friendly to these kids. The other problem is the societal stigma. I think even today, if unmarried girl needs to go to a clinic to ask for contraception, it is kind of a social stigma or a societal taboo even now. So I think that will need maturation from our side as a society. Societal attitudes and stigmas need to be taken care of. Like Dr. Fiji mentioned, there are a lot of stigmas around, myths regarding teenage health, gynecological health. These needs to be considered at the community level. Finally, there are legal considerations. Even today, 18 is the age for consent for a procedure a medical procedure, and also even consensual sex. So if a girl lands up in trouble or has a complication arising out of a sexual relationship, she might not be very comfortable coming out in the open because of the legal implications involved. And even now, she may need to take the help of her guardian or parent to undergo a procedure. And many children may not have a very congenial atmosphere at home. So we might have to consider, this is a very it's a very this issue needs to be actually discussed in detail with the pros and cons, and we may even have to consider policy and legal reforms. Like in Western countries, there are Fraser competence and Gilley competence. All these kind of laws are there. We might have to the changing scenario of our country. We might have to consider all these things, considering the pros and cons. So to conclude, building a teen-friendly clinic requires more than medical expertise. It involves empathy, innovation, and adaptability. The key is listening to the teens, and the best way forward, like Dr. Bhavani said, would be to involve the teens in the setting up and implementation so that we can overcome all the barriers towards it. Thank you.
Thank you, madam. Thank you so much for sharing lots of insights. I hope our discussion will make all of us to make changes, will help us to reevaluate our practices, and will definitely help to make a teen-friendly gynecology OPD in the future, which will prioritize adolescent emotional, physical, mental well-being. I once again thank Kfog and the organizers for giving this chance. Thank you, madam.
Thanks a lot to all the moderator and the speakers, the panelists. It was a very good panel. First of all, I have to thank Dr. Densi for creating appropriate questions and all the speakers who spoke very well. Still, there is a dilemma for me. If the patient comes with the, if we get any chance to know that she is sexually active, when we can consider it as POXO. That's a very dilemma, one thing.
Yes.
And one more thing is, if we consider that we should be very friendly if we have to do any procedure in the teenage, and if we encourage sexual activity, this is going to cause more social crime than whether it's going to improve her condition in future also. So it is going to cause more health issues also for her. So all those things we have to consider.
Yes.
So I want senior members to tell anything about this, especially Dr. Suchitra, madam. She is very expert in this field. Madam, anything you want to tell about this? Actually, when we can consider, because we are considering teen-friendly OPD, and we should be very careful when handling a person who is sexually active. How to consider, even if we come to know that she is sexually active, can we consider it as POXO or not?
Actually, if a patient comes and says she's sexually active, below 18 years, usually, first of all, they won't come with that. But when they tell us, we have to be aware that it is a POXO Act. We cannot take any chances by going against the law. So first of all, we have to advise her that she will get into trouble. This is going to be a big legal issue. And secondly, we can also give guidance. We are also like their mothers. We can tell them you should not get into such activities. You will get into a problem from which you can never get out. So I think sexual activity is becoming more and more common among teenagers. They very casually say that, yes, I had some sex. So we have to advise them regarding the POXO, and unless actively we are involved, we cannot, we can only advise them. We cannot straight away go and give a case, but if we know that if she gives a complaint, we'll have to take some action. Actually, once this laborers, this Bengali laborers had come. And that girl casually said, I'm having bleeding. And then she had come with a young man. We just looked in the OP, we have got ultrasound. Then I saw some products of conception like that. And I have got another assistant gynecologist. Then she said, Madam, this is a POXO case. So immediately I continued looking at the patient. By the time she informed the police station, then the lady police women came. They come in plain clothes and they just very gently, unobtrusively, they took the patient and went. So we cannot take any chances with the law. If in case we come face to face with girls below 18 having sex, we will have to register a complaint. That is my point of view. But as far as friendliness, etc., is concerned, what as Dency was saying, we can be friendly. We can have a very friendly approach. We can talk to them about their dress, their what they are studying, and where they are studying. They will be very open with us. But sometimes they may land up in trouble, and they may land us also into trouble. So we have to be careful of both. What do you say, Maya?
Yes, madam. That was very tricky. That's why.
Yeah, it is a tricky question, but we have to be careful because finally we will also get into trouble. They will also get into trouble.